as an example of the kind of work, the kind of faculty, the kind of collaboration that happens here and will happen here, we're pleased to have Dr. Kenn Daratha and Dr. Michael Ring here to present. Dr. Daratha is a WSU faculty member. He also holds a clerical appointment at the University of Washington College of Medicine. His appointment is in the College of Nursing, and he holds adjunct appointments in the College of Pharmacy and the College of Engineering and Architecture. He is the scientific director of the Institute for Systems Medicine, and is the architect of, founder and architect of the Spokane Community Clinical Data Repository of the Institute for Systems Medicine. His area of interest is focused on the examination of improvements of health outcomes for hospitalized patients. He's worked closely with many clinicians in this community and done really great work. One key collaborator is Dr. Michael Ring. Dr. Ring has worked in the community for 20 years, is a graduate of UCLA and medical school at Vanderbilt, graduate medical education at the University of Arizona and University of Boston, I believe. He is currently the medical director of the Providence Heart and Vascular Institute of Spokane. Among his many contributions, he's been very involved in practice, but also in academic circles and with faculty appointments. He's a past president of the Spokane County Medical Society and the Spokane Society of Internal Medicine, and he is the current governor of the Washington chapter of the American College of Cardiology. His interests include defining and improving quality in cardiovascular medicine, particularly as related to long-term outcomes. We're pleased to have their presentation, and we'll have them both come forward. Thank you.
To introduce myself, I'm Mike Ring. I work at Providence Sacred Heart. I'm what's called an interventional cardiologist. Some people would say that that's a glorified plumber. What that means is I open up blockages in coronary arteries, and I sort of think of it more as a contact sport. What I'm doing is unplugging these arteries that are basically cholesterol plaque that are causing people to have chest pain, shortness of breath, sometimes causing myocardial infarctions and death. In fact, what I deal with is the leading cause of death in the United States and most of the Western world. So I want to acknowledge over here the contributors to this project over here, in addition to Ken, Raleigh Paris, and Denise Dominic from Sacred Heart had major contributions. Robert Short, who's also on staff here at WSU, statistician, and Kathy Tuttle is the medical director of research over at Providence. And over here is my tool. If you can see to the left of the screen, that's what I deal with. That's a angioplasty balloon with a stent crimped on it, and that balloon is expanded. What happens is we deflate the balloon and that stent stays in place. That's how we open up these blockages. Now, the size of it is not as big as that. It's about 3 millimeters in diameter, sort of a typical stent. Almost always when we go in and we have a blockage, we can open up those blockages, put in a stent, and have a 99% chance of acute success. But really what people want to know, do stents last? What's the long-term outcome after these procedures? That's really the question. That's what most patients ask me about it. So you probably are familiar with stents. Those are those metal mesh devices that we leave implanted in the artery to scaffold, open the plaque blockage. You may have heard over the last, it's been about 8 years or so, we've been using what some people refer to as medicated stents, or drug-eluting stents is how we term it. And what those are is it's as compared to what we used to use, which are called bare metal stents, which are basically stainless steel devices. They kind of look like a chain link fence rolled into a cylinder. Well, the medicated stents are the same stent, but they're coated with a polymer that releases a drug that helps to prevent scar tissue from growing inside of the stent. because we know that that happens in about 15–20% of the bare metal stents and leads to re-narrowing of the stent. So the medicated stents were designed to prevent that re-narrowing, or what we call restenosis. So that's the idea of that. And back around the, about 10 years ago, there were a number of very exciting studies that came out that showed that medicated stents could prevent more than 50% of the re-narrowings from occurring in patients. Now, the patients that were studied, and this was per the design of the FDA, were very low-risk patients, relatively simple patients in the world of what I deal with. But the results were just phenomenal. They showed a major reduction in this re-narrowing, and we thought that we had solved one of the main Achilles heels of the procedure. However, as these stents got introduced into the real world, which is the entire universe of patients that not only myself but other interventional cardiologists deal with, is that these patients are much more complex than the ones that were initially studied in these randomized studies that led to the commercialization of the stents. The other thing that we knew with these drug-eluting stents is because they were preventing the re-narrowing of the scar tissue in the stents, it also took longer for the body to coat the stents with the normal endothelial, or the tissues that normally will cover all of the inside of our blood vessels. So we had to use a longer course of these antiplatelet or anti-clotting drugs to prevent clots from forming inside the stent. The problem with any drug, though, is it doesn't know the difference between a bad clot, which are the ones that could form inside the artery, versus the good ones that you might get if you cut yourself. Next slide. So, the first couple years after these stents came out, we thought, this is great, we'll just use them in almost everybody, and that's what basically happened. But after they'd been out for a few years, concerns arose that we may actually be putting a number of our patients in jeopardy by using these drug-eluting stents. And there were some reports that came out of Europe that indicated that there seemed to be a high number of patients who are developing clots inside of these drug-eluting stents at a higher rate than we were seeing with bare metal stents, and that was causing a higher chance of having a heart attack or myocardial infarction. And so there was a lot of interest in trying to sort out this issue. Were we really helping patients or hurting them? And you may recall a few years ago there was all kinds of articles and concerns that came out in the media, and some people even called these drug-eluting stents as time bombs inside the patient's arteries. So we were really very interested in trying to figure out, at least in our patients here, were we putting them at risk by using these drug-eluting stents, or were we really helping them? And that was one of our questions. And there have been a number of ways to try to get to the bottom of this, and I don't want to go into too much detail. It's one thing when you have a randomized clinical study where patients enroll and 50%, like a flip of the coin, get a drug-eluting stent, 50% get a medicated stent. That's great in a study, but in the real world, that's not always possible to do that type of study. And so there are other ways to approach that, and I don't want to go into the statistical means of it. Well, let me go to the next slide over here. So basically, what we were interested in our patients that we were taking care of, which are actually, as you know, Sacred Heart's a very busy cardiac center. We're actually probably one of the top 3 centers in the entire West Coast as far as heart procedures. We wanted to know, in our patients who were receiving drug-eluting stents, we wanted to compare their outcomes to those that we had been treating previously with bare metal stents. So the things that we were interested in were obviously, were we putting these patients at risk? Were they having a higher chance of maybe dying from these stents, of having heart attacks, presumably due to this what we call stent thrombosis or clotting inside the stent? We were also concerned, were these patients being exposed to a higher chance of having bleeding problems as a result of the longer duration of these anti-clotting medicines that we were putting these patients on for at least on the average about a year? And then the other thing is we wanted to know, were we helping the patients? Were we preventing them from having to come back for repeat procedures? We call that TVR, or target vessel revascularization. What that means is if you put a stent in let's say the LAD, the artery that goes to the front of the heart, will we prevent that patient from having another procedure, like another angioplasty, or having to have a bypass operation to fix a new blockage or a re-narrowing in there? So we were interested in that, and we particularly wanted to know, were we preventing patients from having to face a subsequent coronary bypass surgery? That's sorry about that, open heart surgery where their chest has to be basically cracked open. The surgeons don't like to hear that term, but I think you're all familiar with that. It's a type of thing that most patients don't want to have, which is really the primary reason that we offered them angioplasty. So those were the things that we were interested. So we chose to study that by looking at our experience of patients treated before the release of the drug-eluting stents. So we had about 3 years worth of data between 2001, 2003 when the drug-eluting stents became available, and then we compared it to when we started using the drug-eluting stents in almost 90% of patients. So we wanted to see how they did. And that was the question. That's a daunting task when you think about it. We did about 10,000 procedures during that time frame, and we don't have an army of nurses or researchers that can go through tons of paper charts. We needed to do this in an efficient manner, and that's how Ken and I met and decided to collaborate.
As Chancellor Pitchler talked about, this really does represent one of the huge growth areas in Spokane, because oftentimes these studies are performed in academic health centers. And if you think about the design of an academic health center study, we really rely on patients to be treated and to return to that facility. And of course, as Dr. Ring indicated, in the real world, that's really not what happens. We have patients who come in and they're treated, and then they go out to their outlying communities, or perhaps they're seen in another facility. So it was very important to us to get as much complete data capture as we possibly could. And Mike, please chime in on any of this or comments as we go through this. We chose a retrospective cohort design, and really one of the beauties of this system here in Spokane that we're developing is multi-source data, and I'll talk about that in just a moment. But certainly we have INHS, and we have a couple INHS folks with us today, instrumental in the development of these types of research capabilities. We have an Apollo database at Providence, Sacred Heart, which allows us to maintain information about these 10,000 patients that were treated at Sacred Heart. We have the procedure logs. When Dr. Ring performs a procedure, there is a technician who logs every event that occurs, and we use those procedure logs. You can imagine those constitute millions of records when you look at all the details of the particular procedure. We have the death index, which gives us the most complete information as to whether or not a patient has died, which is interesting because as a healthcare system, oftentimes we don't know when the patient dies. If they die within the hospital, we know that, but we don't know if they were discharged and perhaps 3 or 6 months later they died. So we tie to the Social Security death index. And then every once in a while, you have to do the old-fashioned manual chart review. You have to open the chart and get the information that you need, but hopefully we can build systems that we can minimize that as much as possible. One of the strengths of the capabilities here in Spokane, of course, really does rely on INHS. If you're not familiar with Inland Northwest Health Services, this map just shows you the reach of the facilities in which we have a common electronic health record across the region. We only have a few areas in the Inland Northwest where INHS is not serving the hospital information systems needs. What this means for our research is that we don't have to rely on patients being retreated within the same facility. If you were discharged and you lived in an outlying rural location and you went to a community hospital in that location, we know about that. We can know about that. If you were treated at Sacred Heart and subsequently retreated at Deaconess, we know about that. So this represents a huge improvement in our ability to follow patients for these different outcomes. So the particular outcomes that we were interested in this study, mortality. As I indicated before, we can match information anonymously to the death index and determine whether or not the patient has died. Again, if you lived in Arizona during the winter months, but you were treated here in Spokane and you died, we know about that. Again, that's all part of this complete real-world information that we're looking for. If a patient had an MI, a heart attack, we need to know about that. We can pick that information up by the administrative evidence within a hospital, any hospital in the region. But Dr. Ring is pretty picky. He says, I don't want just administrative evidence. I need to know that cardiac enzymes were elevated. And so we match not only the administrative record, but we look at the laboratory records. And we look for elevated troponin and elevated CKMB index. That's one of the terrific things about working with a clinician, is that we get the opportunity to do real-world research. We can't rely, many studies rely entirely on administrative evidence. We can do it one step better in this instance by linking to laboratory data. Bleeding events, we were interested at the beginning because of the use of Plavix primarily. Long-term in these patients, there were concerns about subsequent hospitalizations for bleeds. We could use the administrative evidence to check to see if, in fact, we saw increased rates for bleeds. The revascularization outcomes, both TVR, we can identify through the procedure logs. And for you to think about that for just a moment, this is sort of a complex question. So you were treated, as Mike indicated earlier, so you treated the LAD, you were subsequently retreated. Well, you need to know what vessel was retreated. And so when you start thinking about the level of detail that's required in the old-fashioned way of doing this would have required lots and lots of man-hours. Thankfully, we have machines that can do this work for us now. And then, of course, CABG. Open heart surgery is something that we can identify fairly easily from the administrative evidence that's been done for quite some time. This is our flow chart from one of our manuscripts, and it's difficult to read. Certainly if you need this presentation, request, we'll be happy to provide it to you. But in this flow chart, we started out with more than 10,000 procedures, and we're left with two cohorts. In a retrospective cohort design, we studied patients that were in the bare metal stent cohort. There were 2,510 patients or research subjects. And in the drug-eluting stent group, we had 2,304. There's always some questions about baseline comparability in these two cohorts. As Dr. Ring indicated, this is not a flip of the coin. He makes a decision as to whether or not you'll be treated with one of these devices, either drug-eluting or bare metal stent. So it is important for us to understand differences in those cohorts and to statistically control for those within our analysis. And so this slide just shows you a part of the large number of clinical characteristics that we reviewed on these two cohorts. And as you can see, and this is probably not surprising, but I'll let our physician comment on that, we have seen over time in patients treated for coronary artery disease, increase in the percentage of patients who are hypertensive, as well as those who have diabetes, and then of course increases in obesity. So these are again factors that we need to control for when we're trying to examine differences in outcomes between those two cohorts. Mike, any comments you'd like to make on that?
Right, because remember what we're trying to do is we're controlling, the bare metal stent group where patients treated from around 2001 to 2003. And then the drug-eluting stent group was from 2004 to 2006. And even during that time interim, which you'd think wouldn't be that much, you can see that diabetes became more prevalent, and that we could also show that based on the weights in the hospital, that we had a higher percent of patients who were what we call obese as well. So those are all things we have to control. And a lot of these things are, when you have that many patients, like 5,000 patients, it doesn't take very much difference for there to be what's called statistically significant differences between the groups. Like if you look at the top line, the age, it's really only about a 1-year age difference, which most of us would say 65, 66, what's the big difference? It is statistically significant, and we do have to make a minor correction as a result of that. But in general, though, I will say the groups were really quite comparable, which was good to see.
Good, thanks. So let's get right to the results. We're looking here at a Kaplan-Meier hazard function. We've got two functions here. We've got the green line are patients that were in the drug-eluting stent group. We've got the blue line, patients that were treated in the bare metal stent group. So if you're not familiar with this technique, you can see on the x-axis we have the number of months, in this case, of between treatment and subsequent death. And then on the y-axis, we have the percentage of patients who have died within that time period. So at any point, you can look at this intersection and see it. After 3 years, 36 months, you get the idea that we've already got somewhere in the neighborhood of about 15% of patients that were treated will die. And this is comparable between both the bare metal stent and the drug-eluting stent group. And if you look at the p-value, we don't have to go too statistical for a moment, but the larger the p, of course, we know that it indicates that there are no statistical differences. So this doesn't address quality of life issues. This answers one question: was there a difference in death for patients between the drug-eluting stent and the bare metal stent group? And our research found that there was not. And we'll let Dr. Ring comment when I'm finished here on the implications of these findings. Consider, though, MIs. And in fact, as we were conducting this study early on, you can see 12 months, 24 months, we can see a lower rate of MIs in patients in the drug-eluting stent group. And at times, as we were looking at the data throughout the study, we thought, well, this is a reportable finding. But as you can see, that by the time the study was completed, we followed every patient minimum of nearly 4 years. We followed some patients up to 8 years. You can see that over time that we found that gap narrowed, and in fact, we didn't see then over the entire life of the study, we didn't see that there were any differences in the rates of MI among either of these patient groups.
And before you go on, just to sort of point out, you can notice, though, that the green line, the drug-eluting stent group, for the first 12 months, definitely had a lower incidence of myocardial infarction or heart attack, which was probably due to the fact that we had them on both aspirin and Plavix, these two anti-clotting medicines. But then after a month, what is usually the standard of care is for those for the Plavix to usually be discontinued. And then what happens is that there is a slight catch-up. You can see that the number, both groups continue to have heart attacks at a certain rate. You can see that, by 5 years, about 10% of patients did have a heart attack. But you can see that the drug-eluting group actually sort of had a slightly higher rate of heart attacks, so that they kind of closed that gap. Now, still at the end of 5 years, they had a lower rate than the bare metal stent, but it wasn't, as Ken mentioned, it wasn't what we call statistically significant. There has to be enough of a difference that you can say with confidence that this was not a play of chance. That's basically what the statistics, the p-value, tells us.
Hopefully you're getting a sense of the value of this prognostic tool. The ability for us to observe patients in the real world, to see the rates at which these outcomes, these adverse outcomes, actually occur. What about this question that was raised earlier? One of the primary research questions: are patients who are treated with drug-eluting stents, who continue a Plavix regimen for 12 months following treatment, are they rehospitalized for bleeds? And in fact, our study found that no, that we were not seeing differences in rates of hospitalization for bleeds. And again, on the y-axis, you see the hazard rates among these patients. You can observe then what percentage of patients did, in fact, were hospitalized for bleeds. What about this question of target vessel revascularization? That is, once again, one of your major coronary arteries was treated, and then it was subsequently retreated. And how long did it take for that treatment to occur? And this is the first significant finding that we're reporting, a very small p-value, a 1 in 1,000th chance that we're reporting this finding totally by random error. In fact, we have sufficient evidence to conclude that there are differences in these two cohorts. That is, that the drug-eluting stent cohort did experience less target vessel revascularization than patients in the drug-eluting stent cohort. And then finally, another significant finding: what about this question about the need for open heart surgery? And you can see that roughly, the 5 years following treatment, you can see that just under 4% of patients in the drug-eluting stent group needed to be, as Mike talked about, had to have their chest opened. Not too many. There may be patients in our study that couldn't tell us that they had a stent, but every patient who had open heart surgery knows about open heart surgery, right? They've got the scar to tell us. So this was a significant finding, the freedom, if you will, from CABG as the result of using drug-eluting stents. And to wrap up with implications and conclusions, Dr. Ring?
Yeah, so basically, in summary, what we can say from this study is that, here in Spokane, this data we're presenting is to date, to our knowledge, the longest reported follow-up of patients who were treated with this particular drug-eluting stent. We didn't get into it. There's been basically 2 different types of drug-eluting stents that were available from around 2004. We used by contract at Sacred Heart what's called the Taxa stent, or the drug that's used is called paclitaxel. But this represents the longest report so far, 5-year outcomes in patients treated in the real world, as opposed to this very narrow focused randomized study. And what we can say based on our patient population here in the inland Northwest is that we really could not show that there was any impact on drug-eluting stents in terms of mortality or death or the occurrence of myocardial infarction. But if anything, the trend was reassuring that it seemed to be slightly less compared to bare metal stents. The direction wasn't the right way. The one thing we can say, though, is that the drug-eluting stents did, to some degree, what they were promised. They prevented restenosis and the need for TVR, or target vessel revascularization. But I do want to point out that in the original studies I alluded to, restenosis and repeat procedures were decreased by about 50% or more in a very simple, sort of relatively simple patient population. In our hands, it was only decreased by around 20% or so. So we did get some benefit, but it wasn't nearly as impressive as the original studies, and it has to do with the complexity of the type of patients that we take care of. Could we go to the next slide? I'm sorry. Why don't we go to the one over here? The other thing that was reassuring too is that there was concern that when you start using aspirin and Plavix, in such a large group of patients, that maybe we were putting them at risk for a higher chance of bleeding. But it's reassuring to see that our clinicians were pretty good at picking the right type of patients to get the drug-eluting stents, and we could not demonstrate higher bleeding. And what's really cool about the study is that if say someone had had the stent put at Sacred Heart, but then they got admitted with let's say a peptic ulcer that started bleeding in Colville, well, we knew about that. So that was what's really nice about this particular, about the database that we have. But we saw no difference. The reduction in coronary bypass surgery is probably one of the most dramatic things about this study. And you may ask, well, how come we only prevented TVR by about 20%, yet we prevented the need for subsequent bypass surgery from around 7 or 8% to only 4% of patients needing it? Only 1 in 25 needed to have a bypass over the next 5 years. That's pretty cool. And I think the reason for it is that when we did see re-narrowing, it probably wasn't as extensive in drug-eluting stents as it was in bare metal stents, so that it was more likely to be amendable to repeat treating with additional stents or balloons. So that was our main conclusion, which hasn't yet actually, that's a novel report. No one has yet, to my knowledge, ever reported such a, that there really is an impact on the need for subsequent bypass. So we're excited about that finding here.